welcome back to our next lesson on ventilators, aka vents. If you remember last time, we left off in talking about the two main categories that we will lump the different ventilator modes into. And for this lesson, we're going to talk about the volume control modes of ventilation. And again, if you remember, in volume control, the thing that we are controlling is the volume delivered to the patient with each breath. So now, within volume control, there really are two primary modes of ventilation that we will use. I'm going to include three different modes in here, and the purpose for that, and it will make more sense as we get further into this, but within these modes that I'm going to list out here, there's almost a hierarchy of support. I don't know if this is truly the way to think about this, but it helps to kind of make sense as you're talking through some of the settings on there and some of the differences between these modes. And if we think of these settings in a hierarchy of support, from a high level of support down to a low level of support that we can provide, sometimes it makes a little bit more sense. All right, so the first of these modes that we're going to talk about in the volume control is a mode that we call AC. This stands for assist control. And again, if you are using some of the older vents, or you're coming from another facility where you use different model events, or like I said, perhaps you're out there doing research and you come across a term that's a little bit different. Sometimes you'll see AC referred to as CMV, and this just stands for continuous minute ventilation. The terms are interchangeable. AC is what it's most commonly referred to around here. So the next mode of ventilation that we will often use is what we call SIMV, and SIMV stands for Synchronized Intermittent Minute Ventilation. We'll talk about what really that means here in a minute. And the last mode of ventilation that you will see, and like I said, this one isn't truly a volume control mode of ventilation, but it makes sense when we look at that hierarchy of ventilator support. And this last mode is what we call CPAP, or pressure support. So now that we have these listed out here, what I'm going to do is I'm going to go through and talk about each one and talk about some of the settings that you'll find in here. So let's go ahead and put over here, these are going to be our settings that we have. So we're going to start off in talking about AC. So the settings that you're going to find on AC are, you're going to have a tidal volume, and when you look at the vent, a lot of times you'll see this as VT, but this stands for the volume or the tidal volume that we're going to give to the patient. We're also going to have a frequency, and this is in breaths per minute, a lot of times referred to as a respiratory rate or the rate. Then you are also going to have an FiO2, and the last setting is called PEEP. And for this, I'm going to put a set of settings on here just so that we have some actual numbers to look at when we're talking about our different settings here. So in this example, we're going to have a tidal volume of 350, a frequency of 14, an FiO2 of 40%, and a PEEP of 5. All right, so let's start off by talking about our tidal volume here. And the tidal volume is a measurement of volume that we're going to give to the patient with each breath, and this is measured in milliliters. Now, we won't get into talking about how to calculate out how much volume to give, but just know that there are certain criteria for how much volume a patient should be getting. And oftentimes this is going to be based on their gender as well as their ideal body weight for their particular height. And the reason for this is if you have somebody who is, let's say, 5'10", and they are a thin person, and we compare them to someone else who is 5'10", who is overweight, the size of the lungs for that patient don't change based on the adipose tissue size. So when we look at ideal body weight and calculating out based off of a patient's height how much volume we should be giving them, that's the reason why we do that. So if you remember when I talked about how the volume is actually delivered to our patients, ventilators work in a positive pressure environment. So in order to deliver this volume, the vent has to push with a certain amount of pressure. Now, based on, from breath to breath and over time looking at trends of patients, depending how compliant or how easy their lungs move, or non-compliant or how stiff their lungs are, that amount of pressure that will be required to push the volume of air into the patient will vary. Like I said, sometimes you'll see some variation in this from breath to breath, as well as long term. If we look at very compliant lungs, it's not going to take a whole lot of pressure to push and to fill those lungs up with that volume that we want, as opposed to if you have a stiffer set of lungs, they aren't as flexible. It's now going to require more pressure to push and expand and open up the lungs and the alveoli in order to deliver the volume of air that we want to give them. And when you look at the ventilator, if you look on the screen, you can actually see, depending on what screen is currently displayed, you can actually look and see what these pressures are from breath to breath that the vent is having to give to deliver this volume, as well as you actually will see the measured volume of air that goes in, as well as the measured volume of air that comes out. And typically the air in and the air out is roughly about the same volume, and from breath to breath, the volume that we deliver, in this case we have it set at 350. From breath to breath there is going to be some slight variation in there, but for the most part it's going to be pretty consistent with each breath. Now, moving on to our frequency, pretty simple. Like I said, it's just measured in breaths per minute, and this is how many breaths a minute we're going to deliver. In this case, we're going to deliver 14 breaths a minute, and each breath is going to have 350 mLs. Alright, now for the next setting we have on here, this is our FiO2, and this just stands for the fraction of inspired oxygen. Basically tells us how much oxygen are we delivering to the patient. So, as we all know, room air is 21% oxygen, and with this setting, typically we will see a range that goes from anywhere from 40 up to 100%, which would be pure oxygen that we are delivering. Usually the lowest that will go is 40%. Sometimes you'll see 35, sometimes you'll see 30, but typically 40% is the lowest end that will go. And it is important because the FiO2 will tell you, it's one of the gauges that we look at to see how much support are we having to give to our patient. So someone who is requiring 40% of oxygen is getting a lot less support from us from the ventilator than someone who's on 80%. So it's a good indicator of how much support that patient is requiring to satisfy their oxygenation requirements. And it's important to note that as our FiO2 increases, once we get above 60% and we start to have patients at this level for extended periods of time, we begin to worry about damage being caused to the lungs. So in terms of some of the pathophysiology behind what is happening, we won't discuss that here. We'll save that for another future lesson. But just know that, once we start to go above 60%, long term we do begin to worry about the damage that the high oxygen is going to be causing to that patient. And now our final setting that we have on here is what we call PEEP. PEEP is simply an acronym that stands for positive end expiratory pressure. So in order to explain what PEEP is, we need to think about what's happening with the breaths that we're giving. So we're going to move air in the patient, we're going to move air out of the patient, in this case 350 mLs 14 times a minute. But at the end of expiration, there's a little bit of time until the next breath goes in. And what can happen is if we're not delivering any air, the alveoli, especially down in the bases of the lungs, they run the risk of, instead of being nice and open, they run the risk of collapsing. And what happens now is if you get enough of these alveoli that have collapsed, and as this progresses further, this is the term that we'll refer to as atelectasis, But if enough of those alveoli collapse, then when you go to deliver the next breath, you're not going to have that full surface area of the lungs available. Because again, if you remember, the surface of the alveoli is where all that gas exchange is taking place. So if that alveoli is collapsed, no air is going to get in there and gas exchange can't take place. And that's really the whole point of providing the mechanical ventilation, is to provide that oxygenation for the patient, to perfuse that oxygen across the membrane of the alveoli into the blood so that it can circulate and perfuse our end organs and end tissue. Another issue that comes when these alveoli collapse is when you go to deliver a breath, some of those alveoli will open back up. And then at the end of expiration, those alveoli will collapse back down. And that constant opening and closing, collapsing and re-expanding of the alveoli can actually cause damage, and that will be something that will work against us in being able to adequately oxygenate our patients. The settings on PEEP, typically the lowest settings that we will go is a PEEP of 5. And the PEEP can go up to, usually you won't see it much higher than 20 or 25. If you're beginning to require, high levels of PEEP, your FiO2 requirements are going to also be high at this time, and this may be a time that we look to switch to alternate modes of ventilation in order to provide the support that the patient needs. And so overall, if we look at our settings that we have here for this particular patient, these are actually pretty low level settings, low level of support that this patient would be requiring. And this is where I'm going to stress that it is important when you guys are getting a report that you find out what your ventilator settings are. And the reason for that is it gives you a picture of where you are in the spectrum of support that you're giving. So, in, let's say, an example of your patient is beginning to deteriorate and not doing good, based on where your settings are, it gives you an idea of how much more room do you have to go up in the current mode that you're at, as well as on the opposite end, if you're working to wean down and eventually get your patient off the ventilator, it gives you an idea of how much more room do I have to go down to get to a minimal level of support in order to begin that next step in working towards extubating this patient. And one final thing on that note is know that every single day our goal is going to be working towards weaning our ventilator support, and if a patient is able and capable of doing it, that we should be performing a spontaneous breathing trial on these patients every single day, trying to get them extubated. And in this working to extubate our patients, while it's certainly not what we anticipate or hope to have happen, a certain percentage of patients that we do extubate will have to be re-intubated. And I've heard this talked about more on a provider level, but if you're waiting long enough to extubate your patients to where none of them get re-intubated, then you're waiting too long to extubate most of your patients. Okay, so now that I'm off of that sidebar, the final thing that I want to talk about with this particular mode is what happens if your patient is taking a spontaneous breath. So now in AC, if you have a patient, so let's say the patient we're giving them 14 breaths a minute, but they're waking up, or their natural drive is driving them to take another breath, and so they're breathing above the 14 that we have them set at. How does the vent handle this? And in AC, what will happen is the vent will recognize the trigger from the patient that they're trying to take a breath. So when you contract your diaphragm, that shrinks down, expands your thoracic cavity, and now will cause a negative pressure, and the vent will sense this negative pressure, and it will recognize that the patient is trying to take a breath. So then in AC, when the patient tries to take the breath, the vent will recognize this, and it will provide the full volume that we have set here. So in this case, the 350 mLs. This is important to know because if your patient is breathing 20 times a minute, 30 times a minute, every single one of those breaths that they're taking is going to be this full tidal volume that you have set. Okay, so that pretty much sums up the settings that we'll see with AC and what each of those settings do. So let's go ahead and move on to SIMV. So the settings that you will see on SIMV, so again, you are going to have a tidal volume, you're going to have a frequency, an FiO2. There's another setting that we'll talk about here in a second, and you will also have a PEEP. The tidal volume, frequency, FiO2, and PEEP, those are all going to be the same. There's no difference between those settings and what we just talked about with AC. But the difference with SIMV is we're going to have another setting in here that we call pressure support. And to explain what pressure support is, it helps if we go and, if you remember, we just talked about how AC handles the patient spontaneously breathing. So it helps if we understand the difference now of what happens to the patient who's spontaneously breathing in SIMV. And in SIMV, when a patient goes to take their own breath, the vent will again recognize this from the trigger. But instead of delivering the volume of air that we have set, the vent is going to allow the patient to take whatever volume of air that they want to take. So whether they want to take a small tiny breath or a big large breath, the vent is going to allow them to do that. And then that is where our pressure support comes in and assists with that spontaneous breath. And the analogy that I have for this, and this may not be the best analogy, but if you imagine that if you have a hose, and let's say it's a short hose and you're trying to take a breath through this hose, and somebody on the other end were to blow in as you're taking a breath, it would make it easier for you to take a big breath. And that's exactly what pressure support does for our patients. Is it's a pressure that the vent will push with behind the patient's own spontaneous breath. And this will allow them to take a larger breath. So let me go ahead and write down a set of settings here for this patient. So again, let's say we have a tidal volume of 350, a frequency of 14, FiO2 of 40%, a pressure support of 10, and a PEEP of 5. So again, in this example, pretty minimal vent settings that we could have for a patient. But I do want to talk about the pressure support. So typically 10 is the lowest that we will go for pressure support, specifically when we're on SIMV. You usually don't see this increased a whole lot. Maybe 15 or 20 is probably the highest I think I've ever seen that go up to. But the reason for not going below a pressure support of 10 is if we look at the ET tube that the patient is breathing through, and even some of the larger ones, 8.5, that's still a pretty small tube to be breathing through. And so when a patient goes to take a spontaneous breath, sometimes you'll hear it referred to as a patient, it's like trying to breathe through a straw. So there's a certain amount of resistance that the patient is going to encounter by breathing through such a small tube. And a pressure support of 10, this is going to compensate for that resistance that the patient is going to have to breathe against. So, there's a chart out there that if you look at the ET tube size, how much pressure support or how much pressure is required to overcome that resistance. But generally with a pressure support of 10, you're going to be at or above most size ET tubes, so that when the patient goes to breathe, they're not having to deal with any of the resistance of that ET tube. The pressure support comes into play, like I said, when we look at the patient taking their spontaneous breath, that the vent is going to allow them to take whatever volume they take. So, let's say we have a patient who is taking a tiny volume each time. So they're only taking 75 mLs or 100 mLs or maybe 150 mLs. If we allow this to go on for long enough, the patient may begin to tire themselves out. They're going to become tachypnic. They're going to become agitated and restless. They're not going to be getting enough of the air that they're trying to get or that their body needs, and that's going to cause our patient to be distressed and could potentially cause us to slip back on this slope of how much support that we're having to give them. So if we don't compensate for this increased need of the patient with adjusting some of these other settings, what we can do is we can increase our pressure support. So now that each time the patient goes to take a breath, we're going to push with more pressure, and this is going to allow them to take a bigger breath easier than they would have been able to before. And this leads into, one of the big advantages of SIMV is the patient has to put some effort into their spontaneous breathing. So their diaphragm is going to get exercised. They're going to be putting forth that effort into each of their breaths. And when we think of things in this hierarchy of support from, AC down to SIMV, the effort required on the patient is going to be more, and so therefore the level of support that we're providing is a little bit less. And I think that pretty much sums up our settings and our basic understanding of what SIMV is. Alright, so the final mode that we're going to talk about here is CPAP or pressure support. And CPAP just stands for continuous positive airway pressure. You'll kind of hear these two terms used interchangeably, and in most cases they mean the same thing, particularly when we're talking about patients who are on the ventilator. But like I said, with this particular mode, it isn't truly a volume control mode of ventilation. And the reason for that is when we look at the settings here, we're not actually going to be delivering any volume of air to the patient. So the settings that you're going to see with CPAP is you'll have an FiO2, a pressure support, and a PEEP. So as you can see, we no longer have a tidal volume and a frequency. So we're no longer going to be delivering set number of breaths with a set volume for each breath. On CPAP or pressure support, this is all spontaneous effort of the patient. So every breath that they take, they're going to be triggering every single one of those breaths, and we are just going to be supporting them with some pressure support and PEEP. And again, we're going to be providing an FiO2 for that patient. Now, it is important to know that sometimes, we're just beginning to wake some of these patients up from their sedation, and, we're beginning to try to work towards extubating them, and so we will switch them to CPAP and see how they do with their spontaneous breathing. And know that if a patient just isn't awake enough, or they're just not taking enough breaths, or their drive just isn't quite there, the vents do have an alarm on there that will trigger for a certain period of apnea. So if the patient goes too long without taking a breath, then the vent will flip into a backup rate. Oftentimes it will mimic the settings that we had for SIMV or AC, and it'll flip into a backup rate and provide breaths for the patient. So know that just because you're putting them on CPAP doesn't mean that if they aren't breathing that they're not going to get support from the ventilator. And if that does happen, then a lot of times we make sure the patient is awake, reset the alarm, put them back into CPAP, and let them try again. If they still are doing the same thing, then we may just go back to a rate and give them some time until they're a little more awake, and we can put them back into CPAP and try again. So for this here, let's go ahead and put down another set of settings for this particular patient. So let's say that we have an FiO2, again, of 40%. In this case, we're going to say that we have a pressure support of 5 and a PEEP, again, of 5. And the reason I did the settings this way is because I wanted to hit on one point here. If you remember when I was just talking about pressure support, I was saying typically the lowest that we will go is 10. There is an exception to this, and this is when we are doing an actual spontaneous breathing trial for our patient. And the point of this lesson, I'm not going to go into talking about the different criteria that we use in order to do spontaneous breathing trials and the things we look at for extubating our patients, but I do want you to know that if we are doing a spontaneous breathing trial, we will drop the pressure support down to 5, And then now we know that the patient is going to have to put in actually a little bit more effort into taking each breath than if we were to take that tube out. So if they're doing good on a pressure support of 5, and typically we won't leave the patients with this level of pressure support for, usually it ranges from 30 minutes to not much more than 2 hours. If they do good with just a pressure support of 5, when we take that tube out, it's going to actually be a little bit easier for the patient to breathe. And so, again, if we sort of look at these 3 settings here, I keep talking about this hierarchy of support, where we move from very supported in AC down to a little less supported in SIMV. If we move down now to CPAP, it's a lot less supported. We're no longer giving them the set volume and the set number of breaths. And oftentimes, CPAP is our last stop that we make prior to extubating patients. So, again, not truly a volume control mode of ventilation, but when we look at this hierarchy and you look at the settings that you'll have on CPAP, they're a lot of the same settings that you'll see on AC or SIMV. So it really makes sense to kind of lump these all together, even though it's not a volume control because we are not giving them a set volume. And so now this sums up our lesson in talking about volume control and the most common modes of ventilation that you'll see within this category. On our next lesson, we're going to talk about pressure control mode of ventilation.